So my name is John Emery Streitman. I'm a cardiothoracic and vascular surgeon. After completing 4 years of college and 4 years of medical school, I proceeded to take residency in general surgery, which was 5 years of training, and then after general surgery board certification, completed an additional residency in thoracic or chest surgery, which includes the heart, the lungs, and the esophagus, everything basically confined above the diaphragm. So as a board certified thoracic surgeon, most thoracic surgeons do a fair amount of cardiac surgery. I do heart surgery, obviously, as well as lung and vascular surgery. Cardiac surgery, that's not stents, that's interventional cardiologists that do balloon and stent work on the heart. I do open heart surgery. That's coronary artery bypass grafting for patients who have severe multivessel coronary artery disease. That is valvular surgery, aortic, mitral, tricuspid, and pulmonic valve repair and replacement. We also do now less invasive catheter-based therapies for certain valves, for the aortic and mitral valves primarily. Those procedures called TAVR and mitral clip, or transcatheter edge-to-edge repair is another way of saying that. I do minimally invasive heart surgery, so small incision, aortic valve replacement, small incision between the ribs over here, mitral valve repair or replacement. I do thoracic and abdominal aortic surgery, so patients that have aneurysms, which is an enlargement of an artery in the chest or the abdomen. Again, those can be open surgical approaches or endovascular, meaning working from inside the blood vessel to repair those enlarged arteries. The vascular portion of my practice, vascular surgery, really is in three main territories: arterial disease in the neck, carotid artery disease, arterial disease in the abdomen, again, aneurysms, but also blockages, and then arterial disease down in the legs, what we call peripheral vascular disease or peripheral arterial disease for patients who have blockages in the leg arteries. You'll see sort of a recurring theme here, because the blockages in the leg arteries, the neck arteries, or the heart arteries, that's really all the same disease. It's hardening of the arteries, just in different anatomic locations. As a thoracic surgeon, I do lung surgery for lung cancers, other benign lung diseases. Sometimes that's small incisions and scope instruments, sometimes that's larger incisions depending on the procedure, the amount of lung that needs to be removed, etc. Esophageal surgery, so the esophagus, which connects the mouth to the stomach. Of course, there's malignant conditions, cancers that we sometimes treat, and also benign regions that patients need operations on their esophagus. Certainly, we have a relatively robust 5-year old structural heart program. And when I say structural heart, that's really sort of this association between cardiologists and surgeons to use hybrid technologies to treat conditions that were treated solely by surgical means. Again, that's aortic valve disease with these devices that are called TAVRs, transcatheter aortic valve replacement, where we insert an aortic valve through a groin or a chest or neck incision from inside the blood vessel. We also have similar techniques to try to repair or eliminate leakage of the mitral valve. And so that hybrid team approach is something that is pretty mature here, honestly, and we continue to grow that service line for sure.
Great.
So I don't know that I have one of these stories where there was an epiphany in my life that, some physicians will have had a disease or a condition or an accident or some sort of a moment of clarity where they became sure that medicine was what was in store for them. Some other physicians have grown up amongst a family full of physicians, and I didn't have that experience either. I was always sort of more inclined to math and science, and I think probably always leaned more toward a pragmatic type approach to solving problems in life. So I do have an older brother who's a physician, and so I drafted off of him a little bit. Certainly in college, I would spend my summers trying to peek down the road a little bit. Spend a couple of summers working in hospitals, getting exposed to all the different services in a hospital. Also spent some time in research labs. It became pretty clear to me by the later part of my college career that I was more interested in healthcare than science, industry, education, that sort of stuff. And so Of course, that leads you to medical school, and I was one of the fortunate ones in my medical school class who pretty much loved everything that I saw on clinical rotations. So that at the time seemed to be a little bit of a problem for me because it made it a challenge to decide exactly what I wanted to do, but it also reaffirmed for me that I'd made the right decision by going into medicine. One of the benefits, frankly, of practicing within the corporate structure that I'm in is that we have a transfer center for our division, which makes it easy if there's referring physicians at outside institutions, facilities that may need to transfer a patient from one hospital to another hospital. We're all very accessible from that regard, and I try to make myself very accessible even with regards to patients that are sent from primary care providers and other consultants, because I think it is really easy in this day and age for everyone to be going in different directions. And for the most part, gone are the days where a primary care doctor comes every day to the hospital around on his or her patients that are in the hospital. And so sometimes patients get lost in that machine, so that there's the outpatient side and the inpatient side. And I may have a patient who gets admitted through the emergency room and has a heart attack and needs bypass surgery, and their primary doctor never knows. And so we really try to identify who the outpatient care provider is for these patients. And I really enjoy, whether it's a verbal conversation or text messages or what have you, I think it's really important now more than ever to try to close that loop of communication, because from a primary care provider's perspective, the last thing I'd want to do is be at the grocery store or have a patient's son or daughter in my clinic for another reason, and they make mention that, hey, mom or dad just had bypass surgery, and I don't even know anything about it. I mean, I think from a physician's perspective, that can be embarrassing, but more importantly, from a patient's perspective, then they feel like they're really not connected. And so I think it is important for us, those of us that do primarily inpatient care, to really try to bridge that gap between the inpatient and outpatient sides.